Hello, and thank you for attending this on-demand sharing session titled Clinical Decision Support for COVID-19 Immunizations, State and Local Challenges. I'm Mike Berry. I'm a project manager with HLN Consulting. We are a health information technology consulting firm working with state and local public health and CDC on a number of initiatives in health informatics, including clinical decision support for immunization. I'll start today with a background on immunization evaluation and forecasting, both for routine vaccines and as it applies to COVID-19. Then I'll talk about the immunization calculation engine, which is one freely available open source tool for immunization evaluation and forecasting. Then we'll spend some time talking about the COVID-19 vaccines, the timeline of their rollout, and the clinical rules that apply to them. That will lead into a discussion of some of the challenges that we faced with implementing those rules, both in the clinical decision support engine, as well as at the state and local public health level. And then we'll talk about lessons learned. Broadly speaking, clinical decision support for immunizations can be divided into two groups: evaluations, which tell us at the dose level whether a dose was valid or not, meaning was it administered in a way that's consistent with the clinical recommendations, and forecasts, which at a vaccine group level tell us simply what dose is recommended next and when. For evaluations, there are several things that might make a dose invalid. For instance, a minimum interval from the prior dose might be violated, which means that the dose was administered too soon from a prior dose in the same vaccine series. Or a minimum age might be violated, which simply means that the dose was administered to the patient at too young an age. For live virus vaccines, there are also a set of rules which dictate how close together those vaccines can be administered. And for many of these evaluation rules, there are grace periods to consider. On the forecasting side, some of the important considerations include repeat doses after invalid doses, as well as the distinction between completing a primary series versus booster doses that might be due for the patient. Evaluations and forecasts can be very complex to calculate, which is why we use computerized clinical decision support to help us with it. One such tool that provides evaluations and forecasts is the Immunization Calculation Engine, or ICE. ICE is an open source clinical decision support system. Anyone can download it and run it and contribute to it. And it's built on a platform that is itself open source called OpenCDS. And it's intended to be integrated with health information systems such as immunization information systems, electronic health records, personal health records. The original collaborators on ICE, in addition to HLN Consulting, included the New York City Citywide Immunization Registry, the Alabama Department of Public Health, and the OpenCDS team at the University of Utah. A word about OpenCDS. It's a software platform and a toolkit for developers implementing all sorts of CDS services, not just those based on for immunization clinical decision support. As mentioned, it's open source. It's standards-based. It implements a number of HL7 standards, and it provides a web service interface. This collaborative project is led by Dr. Ken Kawamoto at the University of Utah. So how does ICE work? Well, the inputs and the outputs are pretty straightforward. For inputs, we include the patient's date of birth, gender, immunization history, which includes all of the vaccines and dates of administration for the patient, as well as disease immunity, such as immunity to varicella, as well as some situational parameters, which might include an identifier for a particular immunization schedule, such as a routine schedule versus a high-risk schedule, and an as-of date in case one might want to calculate a forecast either in the future or in the past. Once ICE has those inputs, it provides the following outputs. For each dose that was provided in the immunization history, ICE provides a valid, invalid, or accepted evaluation. Accepted means that the dose wasn't straight up valid or invalid, but that it was accepted for one of a number of reasons which are provided. For doses that are invalid, ICE provides the reason that the dose was invalid. Some of those reasons I mentioned earlier. And then at the vaccine group level, one recommendation for each vaccine group. That might be recommended, future recommended, there might be a conditional recommendation, or not recommended at all. We also provide the earliest recommended due date, as well as the latest, the overdue date, and the reasons for these recommendations. There are several ways to utilize ICE. Immunization information systems and electronic health records typically call its web service API. There is also a FHIR interface whereby electronic health records can display ICE results inside of the EHR using a technology called CDS hooks. And for interactive users, there is a web client publicly available on the web. When the first COVID-19 vaccines were approved in December 2020, ICE was already a mature product and supported numerous vaccine groups in CDC's recommended immunization schedules for both children and adults. So adding the COVID-19 vaccine group to ICE didn't involve any re-architecting. It just involved the careful documentation of the clinical rules and the development and incorporation of those rules into the clinical decision support engine. There were many, many iterations of new clinical rules, new vaccines, and new recommendations. After the initial Pfizer and Moderna approvals and recommendations in December of 2020, February 2021 saw the Janssen vaccine, the Johnson & Johnson vaccine, and then in April 2021, the Janssen vaccine had a pause and a subsequent resumption. Moving on to May of 2021, Pfizer was approved and recommended for adolescents. And then in that following, late that summer, the additional dose for high-risk individuals, as well as the Pfizer FDA full approval occurred. In September 2021, the booster dose for non-immunocompromised individuals was approved and recommended. And then later that fall, an expansion of the booster dose. And then into the winter of 2021, we had Pfizer for the 5 to 11 age groups, as well as an expansion of the booster recommendations. In December 2021, there was a recommendation of the mRNA vaccines over the Janssen vaccine. And then coming into 2022, we had the booster dose for 12 to 15-year-olds, the Moderna full approval in February, followed by booster updates in April, the booster dose for 5 to 11-year-olds in May, and then most recently, last month, the Moderna and Pfizer for the 6-month to 5-year age group, as well as the Moderna for the 6 to 17-year-olds. Throughout this whole process, the clinical considerations from CDC were updated, and the clinical decision support engine was subsequently updated as well. All of the clinical considerations that were developed over that timeline you just saw on the previous slide made their way into the COVID-19 immunization rules wiki or webpage that documents all of the rules for the COVID-19 vaccine group inside of ICE. This is a lengthy document with relatively complex rules for everything from patient age groups to the different vaccine codes and the timing and the intervals. All of those things are captured on this human readable website, as well as implemented in code, which of course can be downloaded as part of the open source distribution. There were a number of unique challenges in the development of the clinical decision support rules for the COVID-19 vaccines that we didn't face with some of the other vaccine groups that had been in ICE prior to 2020. Many of these challenges had to do with the lack of guidelines during the early phases for edge cases and unique situations for which there wasn't enough data yet. So we didn't have, for example, in the very early phases, information on absolute minimum intervals. Those were intervals between the vaccine doses that, if violated, would trigger the recommendation of a repeat dose. We didn't have information on overdue intervals, when to declare a patient overdue for a dose. We didn't have information on the mix and match of the different brands of vaccines and what would the recommendations be in the case of a patient who did mix and match. We also lacked information on rules for when age cutoffs were violated, but the patient wanted to continue the vaccine series either at a later age or right then. And lastly, some of the differences between the emergency use authorization and the CDC clinical guidance needed to be understood. Over time, some of the clinical guidance that was missing initially was ultimately published and incorporated into ICE. In the first 12 or so months after the initial vaccines were approved and recommended, we saw several new guidelines, and we incorporated them in several ICE releases. These included new age groups, the pause and subsequent resumption of a vaccine, risk groups, the definition of risk groups, the question of retroactive application of new guidelines had to be considered, and as well as the non-US and WHO approved but not FDA approved vaccines. Another challenge that we saw coming into the later parts of 2021 was the question of the difference between clinical vaccination status and what we might call administrative vaccination status. And what we mean by that is that you might have had a patient during that time who was still due for a dose of vaccine, such as a booster dose, but that meets administrative requirements for school or work or venue entry because they're fully vaccinated with the primary series. Ultimately, what this resulted in is a distinction between fully vaccinated, which generally meant a patient who is vaccinated with the primary series, versus up to date. Up to date is a patient who has received all of the doses that have been recommended, including booster doses. The challenge here is the desire to recommend booster doses for those who are eligible, but to also convey a sense of the series complete for those who have completed the primary series. So CDC says when you are up to date with your COVID-19 vaccines, when you have received all doses in the primary series and all booster doses recommended for you when eligible. So those vaccine recommendations, of course, are different depending on your age, the vaccine you first received, and the time since your last dose, not to mention whether or not you are in a high-risk group such as immunocompromised. So in the next few slides, we're going to look at some example patients using the ICE web client in order to illustrate the concept of up-to-date. And we'll see patients who are up-to-date versus not up-to-date based on their vaccine history and their age. The ICE web client in its dose view shows doses and evaluations on the right side and vaccine groups and their recommendations or their forecasts on the left side. And so here on the right side, we have a patient who is 47 years old who received 3 doses of the Pfizer vaccine, dose 1 and 2 in the spring of 2021, and then a third dose in November of 2021. All of these when the patient was 46 years old. And then we can see here on the left that there is no recommendation for a future dose, except for what we call a complete, a conditional recommendation if the patient had risk factors that would put the patient into a high-risk group. That would call for a recommendation. Otherwise, there is no recommendation for a vaccine. So this patient, assuming the patient is not in an immunocompromised or a high-risk group, this patient is up to date. Here we have an older patient with exactly the same dose history. We have dose 1 and dose 2 of the Pfizer vaccine in spring of 2021 and third dose in November of 2021. This patient, however, because the patient is over the age of 50, ICE is recommending a booster dose, and because that third dose was given in November of 2021, which is more than 5 months ago, this patient is recommended for a booster dose now. Here we have a third example patient. This one is a 46-year-old who, instead of getting the Pfizer vaccine as part of the primary series, this 46-year-old got the Janssen vaccine in spring of 2021, and then got a Pfizer vaccine in November of 2021. So what the clinical decision support engine is doing here is it's determining that the primary series was completed with this 1 dose of the J&J vaccine, and that the booster recommendation was satisfied with this Pfizer dose later that year. So we have a patient with only 2 total doses, and the clinical decision support engine is not recommending any further doses. This patient is up to date. Again, if the patient were over the age of 50, then the patient would be recommended an additional booster dose. Looking at one more example, here we have a 47-year-old who is like the previous 47-year-old Pfizer patient, except that there's no second dose in the spring of 2021. What we have here is only 2 Pfizer doses, 1 in the spring of 2021 and then 1 in November of 2021. So that dose would have been a booster had there been a second dose in the spring, but because there's not, this patient is still due for a booster dose. So the clinical decision support engine is looking at the history here and looking at the age and is making a determination in each case as to whether or not the primary series is completed. If it's not, then the recommendation is to complete the primary series. If it is, then we're looking at booster doses so long as the sufficient interval has passed. So the clinical decision support engine is doing all of this for us. If we're an IIS or if we're an EHR trying to make recommendations for the patient, or if we are a health department that is maintaining a dashboard and trying to ascertain the status, the vaccine status of these patients. The clinical decision support engine is helping us do that by giving us the status through the forecast for each patient. So you can see from those examples that being able to look at the evaluations and the forecasts or the recommendations for vaccines and for the vaccine group can help to convey the patient's vaccination status, which is an important piece of information along with the actual dose administration history. And that information can be useful for many parties, not just the immunization information system or the electronic health record. During COVID-19, there were more downstream consumers of IIS, of Immunization Information System data, than ever before. CDC operates its data clearinghouse through which the IIS send data ultimately to land in the CDC data lake, which is used for the CDC COVID-19 dashboards. In the states, we have the Department of Health epidemiologists looking at the data. You also have state and local COVID portals and dashboards that are taking IIS data and presenting it in various formats to the community and to other stakeholders. Providers are using IIS data to know which of their patients are immunized and which are not. Payers are doing the same thing for their covered lives. Patients themselves, more than ever before, are accessing their own immunization data through portals and other means operated by state and local health departments and their partners. And lastly, other IIS in other jurisdictions are also consuming IIS data from numerous jurisdictions, both through the CDC's IZ gateway, immunization gateway, and just through direct connections from IIS to IIS. The thing is, though, not all of these downstream consumers accept or interpret or even know what the evaluations and recommendations are for the vaccines. So many of them, because all they're getting is the vaccine history, many of them are limited in what they can do with that data. And you can see those limitations manifested in various downstream presentations of the data. On the slide here is one of the more popular downstream presentations known as a smart health card, presented here on a mobile device for the patient. And what you can see is that we have the patient's name, and we have the vaccine, and we have dose dates. And we also have this 3D barcode, which encodes all of this information, as well as the patient's, some of the patient's additional information not shown here, such as the date of birth, as well as an electronic signature from the issuer of the card. So it's a very sophisticated presentation, but one of the obvious things that's missing here are the evaluations and the recommendations and the vaccination status of the patient. We don't know, just by looking at this presentation, whether those doses were valid or consistent with the clinical recommendations, nor do we know what the vaccination status of this individual is. We don't know if this individual may or may not be up to date in terms of whether or not a booster dose is due. We could, this one is simple enough that we could sort of do the math ourselves and think about the rules and determine that, well, most likely, even though this patient's date of birth is not here, we can assume that if dose 2 of Moderna was administered on January 29th and we don't have a dose 3, this patient is probably due for a booster dose. But nothing on this card explicitly says that, and the information that is presented both in this 3D barcode as well as printed on the card itself, it doesn't tell us, whether or not the patient is in fact up to date, or whether the patient is due for any doses. This is just a very simple presentation of the doses, the dose history. And we see some of the same limitations when IIS data is sent downstream to a dashboard. What we're looking at here on the left is the CDC interactive COVID-19 vaccination dashboard. It's an interactive map of the states and jurisdictions, which when clicked takes you to the individual dashboard for that state or jurisdiction. And the majority of these dashboards have metrics such as what we see here on the bottom right: persons with at least one dose, persons with vaccine courses complete, and this is defined here as persons who have completed their primary series, which essentially means 2 mRNA doses or 1 J&J dose. So these are relatively easy to calculate without having evaluations and forecasts from a clinical decision support engine. It's only a few of the states and jurisdictions that have dashboards that look like the one we see here on the upper right, which includes not only 1 dose and completed the primary series, but also includes people up to date with vaccine doses. So this one is a little more difficult to calculate, and depending on the data coming downstream from the IIS to the process that generates the dashboard, the amount of calculation that's the clinical calculation that has to be done in order to achieve this number is much more significant than these other 2 numbers. So what we're seeing essentially is a spectrum of from relatively simple to more complex dashboard measures, and the amount of clinical decision support needed to support the measures increases as we go from top to bottom here. So in order to calculate the number of people with at least 1 vaccine dose, it requires very little clinical decision support. Some of the dashboards may invalidate doses that are administered to too young, but not necessarily. Some of the dashboards may just be counting doses regardless of patient age, and in which case this is a relatively easy metric to calculate. But as we get into some of the other measures, they are a little more tricky to calculate without having clinical decision support to lend a hand. So people with completed vaccine series, and what that typically means on most of these dashboards is the primary series, either 2 doses of the mRNA vaccine or 1 dose of the J&J vaccine. And that's a little more difficult to calculate than just people with at least 1 dose, because now you have to look at whether or not the first dose was mRNA or if it was J&J, and then make a calculation or a decision that, if it's J&J, then only 1 dose is necessary. If it's mRNA, then 2 doses are necessary. And then some decision making also has to occur related to, what if the patient got a mix of the 2? And also there are the considerations, now that we're talking about more than just 1 dose, at least in the case of the mRNA, you now have the consideration of the interval between the 2 doses to consider. And if the interval is too small, then the dashboard may choose to not count that patient as having completed. The dashboards tend to have footnotes at the bottom that indicate, what rules they follow. Now we get into people with first booster and second booster. We're grouping these together because typically in the different dashboards, you have dashboards that show just this one simple measure. Then you have another set of dashboards that go sort of the next step, which is to the completed series and the first and second booster. And then we have the most sophisticated, which is people up to date. So first and second booster, now that requires that not only do we have to calculate whether or not the patient has completed the primary series, but we now have to look at the interval between the completion of the primary series and the first booster, the interval between first and second, and whether or not the patient is eligible for a first booster based on age, and eligible for a second booster based on age, right? So we have patients in the youngest age groups, depending on time, who are not eligible for first booster. We have patients under 50 who are not eligible for second booster. And then lastly, the people up to date. Again, that has several factors because it, depending on where the patient is in their vaccine series, if they've just had their first dose, but sufficient time has not passed until they're due for the second dose, that patient is up to date. If they have completed the series but they're not ready for their first booster yet, or if they've completed the series in the first booster but they're not old enough for the second booster, all of those patients are up to date. So there's a lot of calculation there that needs to be done. And ideally, you'd like to have it done by the clinical decision support because it has all of the rules in one place, and those rules have been well thought out and documented. So if the CDS does that, then it has to get the information downstream to the partner that's generating the dashboard measure. And all of this talk about dashboards really brings up the next major set of challenges, which has to do with the fact that on the one hand, the data quality of this COVID-19 vaccination administration data going from providers and mass vaccination facilities to immunization information systems is leaves a little bit to be desired, and at the same time, the demand for the timeliness of the data in order to populate these dashboards is higher than it would typically be for other vaccine groups. So we have this sort of dual problem of data quality issues that need to be resolved, but the demand for timeliness, which makes it difficult to have the sufficient time to resolve the data quality issues. Those issues include duplicate doses. We have some providers who report the same dose twice for a patient, but on different days. Or we might have a provider that reports a dose for a patient and then shares that dose with another provider or entity, and then that provider reports the same dose, but unfortunately they get the date wrong, and so there's a duplicate dose. Incorrect vaccine codes is a common problem. This has to do with often at the point of care, the user interface makes it the user interface of the point of care software, whether it's an electronic health record or something else, makes it easy for the clinician or the person who is documenting to make a mistake in the vaccine code that is selected. It's also relatively easy in any kind of data entry system to enter an incorrect date. Sometimes that's relatively harmless, but when we're talking about looking at minimum intervals, then an incorrect date can be very damaging to an individual's vaccine record because it can make it such that the intervals are violated and the patient is not considered to be either fully vaccinated or up to date, depending on where they are on the schedule. So all of these data quality issues are being resolved, while at the same time, these downstream partners are in need of the data as soon as possible. And of course, all of this is in the context of that lack of clinical guidance in certain edge cases and unique situations that make it difficult to identify some of the data quality issues. So, for example, when there aren't absolute minimum intervals defined between vaccine doses in a series, it's much more difficult to identify duplicate doses and rectify them because they can't be invalidated because there's no absolute minimum interval. So these are the kinds of data quality challenges that we have. And again, it's in this environment of we need the data as soon as possible, always. So stepping back and tying this all together, in summary, the development and the approval and the recommendation of the COVID-19 vaccines starting in December 2020, and then the subsequent releases of new vaccines, new age groups, booster dose recommendations, and new vaccines led to a lot of new and unique challenges for immunization evaluation and forecasting. Despite these challenges, the clinical decision support from tools such as ICE really helped IIS and their partners determine the vaccination status of their patients. Unfortunately, in many jurisdictions, the data that was flowing from IIS to external or downstream systems was the raw data, or just the vaccination history, without the evaluations and the forecasts. And that's the data that was going into the systems, and still is, that populate public dashboards and provide digital credentials, such as the Smart Health Card. So because this clinical decision support data that's available from the IIS is often not conveyed with the vaccination dose data, that can lead to a misinterpretation or an overcounting of the validity of current doses, as well as the absence of a reliable prediction of future doses. And if you can't see that forecast for future doses, it's much more difficult to determine at the individual patient level whether that patient is up to date or not, which leads to an overuse of measures such as patients who have had one dose, patients who are fully vaccinated with the primary series, which essentially means 2 mRNA doses or 1 J&J dose, as opposed to the more sophisticated measure of up to date, which is how many of my patients in whatever jurisdiction we're looking at are up to date on their vaccines. They've gotten all of the doses that they are recommended for. So overall, explaining the nuance behind CDS for immunizations and ensuring that systems that rely on this data take and interpret that data properly, it will continue to be a challenge for public health agencies. As you can see, it's much easier, of course, to simply take the raw vaccination data from IIS and to produce those relatively simple measures. But as time goes on, it's very clear that the measure of up to date is the one that is going to stand the test of time, because no matter how many boosters we have, up to date will always be a measure that can be compared apples to apples over time. So that's the last slide in this information session. If you have any questions about ICE, the immunization calculation engine, feel free to visit us on the web at www.hln.com/ICE. There you'll find the wiki with all of the rules, as well as all of the releases and the release notes. You can download the software because it's open source. The source code behind the software is available, as well as the source code repository where you can view all of the changes that have been made and submit pull requests, which are essentially contributions to the software as you wish. You can also email us at ice@hln.com and any questions you might have, and we'll get back to you as soon as possible. Thank you very much for your attendance in this session. I hope it was valuable and you gained some useful knowledge from the session. Thank you. Good night.